Okay, so I think we might sort of kick off and do sort of some of the introductions and that side of things, so that we've got plenty of time for Marlena to be presenting and to be asking questions. Before we kick off, I'd just like to do an acknowledgement to country. I'd like to pay my respects to the traditional custodians of the land, wherever you might actually be. With us being sort of all online, we're all sitting on different lands these days, and pay my respects to elders past, present, and any Aboriginal elders of the community who may be with us today. So it's my absolute pleasure to be introducing you to Marlena KLaic, who's going to present to us. I've had Marlena in mind and been chasing you down in my mind for some time, Marlena, to be doing this presentation today. I was kind of like, how long is sort of long enough for me to be polite and not harass you? Hopefully we've sort of managed to hit that okay. Marlena is a postdoc fellow at the University of Melbourne under Professor Jill Francis. She's got a clinical background as an occupational therapist. And end of last year or the beginning of this year that the implementability paper came out, Marlena?
Beginning of this year. Beginning
of this year. So, and a really, really interesting paper that Marlena is going to be talking us through the framework and thinking around a framework when we're considering implementability of complex health interventions. So without any ado, perhaps Marlena, would you be okay if I hand over to you? Just to be saying to people, obviously, you know, we always really love the discussion that we have sort of through these meetings. So if people want to pop any questions or comments in the chat, we've got time at the end, and obviously, you know, sort of we can you know, so we can unmute people and have chats at the end as well. I'll stop talking at that point, Marlena. It's over to you.
Thanks, Steph. Are you seeing the right screen here? Because you know how I have that moment where it's like, oh.
Perfect.
Brilliant. Thank you. And thanks so much for the really lovely discussion. And I am really excited to share this work with you all today, and happy to actually take questions as we're going through, or as Steph said, if you want to pop them in a question or in the comments box, and we can have a good chat at the end. It's not going to be a long presentation today. I will go through bits and pieces of the framework, but my ideal in these types of situation is to really have lots of robust discussion, particularly from a group of experts, which you all are. So getting your thoughts and opinions and some good discussion going would be ideal from my perspective. So I'm going to get started. And this is pretty much in a nutshell what I'll talk about today. I'm going to go through some pretty basic preliminary stuff. And the main reason I'm going to do that is kind of to paint a story around how I came to be doing this sort of work, why I've found it to be really important, and you know how I actually came to think about what other factors might influence adoption. So I am going to go through a personal sort of clinical story, as Steph introduced me earlier on. I do have a clinical background, so I'll start the presentation talking about that, and then move on to factors and processes and strategies that we know support knowledge translation, and ones that we think might support knowledge translation, with a particular focus on a framework that we recently developed and that Steph just described. So let's get started. As Steph mentioned, I'm an occupational therapist, and I've worked in neurosciences with a particular interest in upper limb rehabilitation. So that's my clinical background. And like most clinicians, and I'm not sure how many of us have a clinical background that are attending today, I'm going to assume at least some of us, we've been trained to be evidence-based. And we all know that evidence-based practice looks like those three circles that we see on the screen there, that best clinical decisions are thought to integrate information from published research evidence, as well as our clinical expertise. And certainly in more recent years, we've started to pay more attention to patient values as an important factor in clinical decision making. But I want to take you back to tell you a story about something that happened to me a few years ago. So I started a new role in a fairly major health service as a senior clinician, and I arrived bright-eyed and bushy-tailed, as you do, ready to see my patients and deliver evidence-based care. And one of the first patients that I saw had an upper limb impairment and met all the criteria to be a candidate for functional electrical stimulation, FES. So just briefly, for anyone who doesn't know what that is, it's low-level electrical impulses to weaken muscles, generally as part of a motor retraining program. And it's an intervention that's got quite a lot of primary research and systematic reviews, and it's endorsed by the National Stroke Foundation. So it's pretty much standard practice for most health services. So I looked around for an FES machine, and I couldn't find one, which is quite puzzling to me. And when I spoke to other senior staff, I was told, in no uncertain terms, we don't do that here. And on further discussion, I was told that they didn't agree with the evidence. So that was despite the fact that it was included in guidelines, clinical guidelines, systematic reviews, and as I said before, many primary studies. And it took me about 2 years to change clinical practice and introduce the option of using this evidence-based treatment with eligible patients. And I think this is a really important example. Certainly for me, it was an important example where I couldn't deliver an evidence-based intervention to my patient, even though it was recommended and even though I had the clinical expertise. The patient wanted the treatment and there was plenty of evidence to support it. So it's an example of other factors at play beyond a treatment being evidence-based. So I'm just going to quickly have a look at the research translation pipeline, just so we can, I guess, go back to how evidence is supposed to translate into practice change. Okay. This is probably something that we all look at on a regular basis. Maybe it's just me, I don't know. And I'm sure that's something that we're all very familiar with, the research translation pipeline. So if we have a look at this research translation pipeline, it looks pretty seamless to me. It suggests that, if we find evidence of effectiveness, say in laboratory or in basic research phase, that means we could and should then go on to test our idea with humans. And then if we're successful in that preliminary phase of effectiveness within human research, then we should move on to further testing of the idea, maybe to other settings, perhaps to other populations, in an effort to develop, I guess, policies, practices that are evidence-based, and so on and so forth. And I do really like coming back to that research translation pipeline as, I guess, an idea of how things should happen. And it looks pretty seamless to me. Sort of looks like almost a bit of a domino effect, one stage to another. But I think there's some assumptions there. And at least one of the assumptions is that once we have evidence of effectiveness at a particular stage, that will automatically move on to the next stage. And I'm sure I'm preaching to the converted when I say that there's a lot of research now, and by now I mean at least in the last 10 to 15 years, suggesting that there's a failure across all of those phases to translate research. So some of these failures or some of these assumptions that underpin the translation pipeline, where we can get leakage of evidence or leakage of that translation. First up, we're assuming that the end user is aware of the evidence or aware of a practice gap. Next, we're assuming that the end user finds the evidence or the idea of the intervention acceptable. And I'm going to talk about acceptability in more detail later. But I do want to touch on here saying that there is growing research to suggest that end user acceptability is important, but it's not well included in a lot of research, particularly in the earlier stages. Next, we need to determine if the research is applicable to the patient group, and also, are we able to apply it? And by we, I mean clinicians, as well as teams and those who fund research, etc. So the question here is, do we have the equipment? Do we have the training? Do we have the time? Can we act on our intention? What if there are competing interests, such as discharge pressures? And do we agree as a team that this is the evidence that we wish to apply? with this patient on this ward, with this population? And finally, can we adhere to the intervention once the pilot's finished, or once project funding is withdrawn, or once staffing profile changes? So the leaky translation pipeline, I know that it's not new information for any of us that work in the field of knowledge translation or health services research. And as a clinician and as a clinician researcher, it really resonates with me. And it kind of makes sense why we don't see a lot of research translating to practice change or to consumer behaviours. And we know there's been a lot of research that's explored strategies and methods that can help us patch the leaks. So one area, and I'd say this is probably the most widely published area, is implementation strategies. And if we were to look at those and broadly categorise them, there are top-down approaches. And that includes things like incentivisation, governance arrangement, national policy, so like the clinical guidelines from the Stroke Foundation that I had on a previous slide. It also includes bottom-up approaches. That's something I've done a fair bit of. So looking at perhaps the views and perspectives of healthcare professionals, either at the team level or the individual level. We've also become increasingly aware of context and how that might shape or interact with implementation strategies. And I think that that's been really nicely highlighted in the most recent update of the MRC Complex Interventions Guideline, where I think they really elegantly argue about the need to investigate complex interventions in each context and in each population. I'm going to touch on that with our framework as well. But we think there's an additional lever for supporting implementation. And by we, I mean myself and the research group or the authorship group that recently published our framework. So we believe that the perceived features of healthcare interventions themselves actually also influence implementability of healthcare interventions. And we're proposing that acceptability, fidelity, and feasibility are the important perceived features of these healthcare interventions. And what we think is that those three features have a relationship with sustainability and scalability of healthcare interventions. So I'm going to walk you through why we think that. When we started to think about different features that might be influencing implementation, we had a bit of a roundtable meeting, and we were talking about things like acceptability, that was increasingly becoming something that was being discussed in literature, and fidelity and feasibility and scalability and sustainability. So the authorship group had a sense that these terms were increasingly appearing in published literature. And when we went to the literature and we did a really quick search around over the last 20 years to see whether these terms actually were growing in interest. And the graph that you see there actually shows quite nicely that, say, from the year 2000, most of these terms had been increasingly seen in published research. So if we have a look at acceptability, which is the blue one, we can see that it started with a relatively low, like I think it was less than 100, it might have been 30 publications in the year 2000, and that had gone up to well over 1,000 by the year 2020. So it seems that these 5 concepts are part of what we call the implementation zeitgeist. What we didn't know at this stage was how these concepts might be related to each other, or if they'd been theorised in the literature in a model. So to answer those questions, we started a bit of a journey. We decided to look at any publications or overviews or reviews, systematic reviews around those particular terms. And then we also convened an expert panel to help us develop and refine a testable framework of implementability of healthcare interventions that included those 5 concepts. So implementability might be a term we're familiar with. I know it's been published around implementability of clinical guidelines. We've defined it as the likelihood that an intervention will be adopted into routine practice and into health consumer behaviours across settings and over time. So what were the results from our overview? We found 252 systematic reviews on healthcare interventions related to those 5 terms. And out of those 252 reviews, only 4% of healthcare interventions had achieved sustainability. It was kind of shocking to me. In some ways, it sort of wasn't when I thought about it, but still to actually find that in a very concrete way really gave us pause for thought. And 9% had achieved scalability, which we defined as behaviour change. So not just dissemination of evidence, but actual change in clinician or consumer behaviour. So we had two key findings that came from the overview of reviews. And the first was that the 5 concepts appeared to be related. And the reason we found that was that in the systematic reviews on feasibility, for example, it often included measures on implementation of the intervention, which is also included in frameworks on fidelity. So there was overlap between most of these concepts, or there were components of each of the concepts in other concepts. So for example, reviews on sustainability included resource use and funding, which overlaps with feasibility. The second key finding that we had was that each concept was important, but not sufficient on its own. And that was really important for us in terms of developing a framework. So acceptability, we found, was an important factor, but on its own, it doesn't necessarily make the difference in terms of adoption. So acceptability, we found, was an important factor for fidelity, but other factors were also necessary, such as provider training. From the basis of the findings from the overview of review, we developed a preliminary framework, and we presented that to an expert panel. So the expert panel, they really were incredible experts. They had a wide breadth of experience in clinical, academic, research, theoretical expertise. So we had oncology researchers, physiotherapy researchers, people who, as it says, theoretical expertise. And 5 of those experts shared a clinical research scenario from their own practice to test using the framework, or to discuss it in relation to the proposed framework. So it's a fairly robust process in terms of critiquing and refining the framework. And I have to say that actually took quite some time. So from the original proposed framework to the final agreed on framework wasn't really necessarily 1 or 2 drafts. There were multiple drafts until we were able to achieve consensus across the panel, which is fantastic. It certainly helped us feel more confident in terms of the framework. So this is a conceptual framework of implementability of healthcare interventions. So if you have a look at that, I know it looks quite busy and I hope you can see it. It was quite tricky to sort of get the PDF of it to look nice in the PowerPoint. But the way it works is that it prospectively guides research activities iteratively from left to right and from bottom to top. So if we look at left to right, sustainability over time, and top to bottom looks at scalability as a component of reach. So if we have a look at the lower left-hand corner, we begin in the research context, where we propose that acceptability is the first concept to assess, or it's the first concept that one should assess during the development of an intervention or an innovation. And if acceptability is adequate to the providers and potential recipients, then we would argue that it's appropriate to deliver the intervention and assess fidelity. And we would also say that without adequate acceptability, providers and recipients aren't likely to engage with the intervention, which would in turn affect fidelity. And adequate fidelity, of course, requires other factors, as I mentioned earlier on, such as training, manualisation. And if we can't achieve fidelity, then we would argue, or would suggest, that it would be wasteful to conduct a feasibility study on the basis that if you can't deliver an intervention with fidelity, it seems pointless to go on and do a feasibility study. And again, there are other factors that are important for feasibility, not just fidelity, but things such as resources and workforce technology. And then we would suggest that if feasibility, acceptability, and fidelity are adequate in the research context, that it's then appropriate to consider testing these concepts again in a healthcare context. And we see that as an issue of scalability. And it's not something that I've really seen a lot in the literature, this consideration that when you develop an intervention, even if it's tested in a healthcare context, that it is still a research context, and that if we're looking then at how that might be implemented as part of everyday or routine clinical practice, that's an issue of scaling from one context to another. And if adopted consistently in one healthcare context, it's appropriate to consider scaling it to other settings and maybe other populations. And that as we do scale up to other settings and populations, we would suggest that you need to reassess acceptability, fidelity, and feasibility. These are dynamic constructs. I know from my own experience as somebody who has engaged in pilot studies of feasibility studies in a research context, that once you move from the pilot phase or the feasibility phase, that often things fall down, that acceptability and fidelity and feasibility may actually change at that transition time. So that you can't assume if you found that this whiz-bang intervention is great and the end users think this is really U-Butte and there's high acceptability, that once you pull out the project resources, or once you're looking for the nurse unit manager to fund it, or the health service to continue to invest in it, you can't assume that it's still going to be acceptable. So hence our argument that acceptability, fidelity, and feasibility warrant reinvestigation as you scale from one setting to another, as well as potentially over time. And that's something that I've thought about as well. At times you'll have an intervention that has had great adoption and it might stick, for a good 5 or 6 years, and then something changes. So over time, it might be that staffing profile changes, or perhaps it's that, I don't know, the physiotherapy manager changed, or maybe it's even more broader than that, that health service focus or funding focus has changed, which means that that intervention may no longer be acceptable, or perhaps it can't be delivered with fidelity or feasibility. So with this framework, we're not suggesting that there's a causal relationship between those concepts. Rather, what we're saying is, for healthcare interventions to be successfully scaled and sustained, they depend on preconditions. And those preconditions are acceptability, fidelity, and feasibility. And as I said, that they need to be re-examined over time because they're likely to change. They're dynamic. Health services are dynamic. Most of what we do is in these environments that are constantly shifting and changing. So it's no surprise that these concepts would also change over time. So when we submitted the paper, we had some fantastic feedback from some of the reviewers. It'd be great to get feedback from you guys as well. One of the questions that they asked were, well, how do you know that there aren't other concepts related to implementability? Which I thought was a fantastic question. So I went back to the literature and selected 3 specific healthcare interventions from memory. I think one of them was telehealth exercise interventions. Another one was a cancer type of intervention. So fairly well researched healthcare interventions, and had a look at if there were other concepts related to implementability over the last 20 years for these particular healthcare interventions. And we didn't find any, aside from acceptability, fidelity, feasibility, sustainability, and scalability. So we felt reasonably confident that those 5 concepts are the ones that have some relationship with adoption of healthcare interventions. I'd be the first to say that we don't yet know what the nature of the relationship is between these concepts. We don't know if it's linear. We don't know that, if the more acceptability that you have, the more adoption that you have, or if it's a threshold relationship. So is there a cutoff point at which enough fidelity or enough feasibility suggests you'd have good adoption? That's work that we need to focus on in coming up. We also don't have direct evidence that acceptability, fidelity, and feasibility predict sustainability and scalability. Anecdotally and intuitively, we think it's the case, but it does require confirmation. And again, I would love to hear other people's opinion on whether you think that these three concepts might actually, predict something like sustainable adoption of a healthcare intervention. We also don't know if there's anything missing. We've gone to the literature and we've relooked, but that doesn't mean that with time that other concepts become increasingly important, particularly as we continue to do lots of research in the space of implementation research and science. We have started to incorporate the framework in some upcoming grant proposals. So fingers crossed that we'll be able to actually test some of these questions that I've just posed. But I'm very interested in hearing your thoughts about the framework and any questions that you might have with regards to development, or how you think that it actually sits in this space of implementation science. That's it for me.
Thank you so much, Marlena. Absolutely fascinating. I've read the paper and we've talked about this paper a few times, but I always get more each time I hear you sort of presenting on it. Of course, I've got a whole heap of questions that I'd like to ask you, but is there anybody on the call who's got a question or a comment that you might want to make? I think there might be some comments. Andrea, I just saw your actual physical hand.
Yes. That was fantastic, Marlena. Thanks so much. What I was interested in was the fact that you've plotted out as acceptability as being the critical first step, and how that contrasts with what you found when you searched PubMed that found feasibility seems to come out way ahead of acceptability. I mean, to me, I agree with you completely. Acceptability seems to be the logical first step. So I suppose it's just a comment. Can you comment about that at all, about the difference that there seems to be?
Yeah, absolutely. And gosh, I've talked about them as separate concepts, but there is so much overlap between them. And feasibility at times included acceptability as a construct in some of those studies, and at times it didn't. So, it was a really messy space to try to sort of, unpack, how much of this is related to that, how much of it is a separate construct. But yes, you're quite right that a lot of studies show high feasibility, but very few of those studies actually translate into sustained practice change. But how many of those studies actually consider acceptability is hugely variable. Whereas we would say that acceptability is a separate and earlier concept to consider before feasibility, even though there is it's almost like they're nested into each other. So there is that overlap between those three terms, but we're saying that acceptability should be looked at ideally prior to, or at least as part of that early sort of workup, because by the time you're looking at feasibility, it's a big investment in resources. And if your end users don't find it acceptable, I would question how you're going to have successful implementation. So we've tried to pull it out and say, this is the earlier one to potentially look at. I hope that's sort of
it sounds completely logical. And I mean,
to
me,
it does sound logical, yeah. But and we talked about this the other day. It sounds really logical, especially when you're writing it up in a grant. But it's untested. It makes sense, right? You think, well, of course, well, who wouldn't say that? But it's in that category of it seems like a good idea.
And maybe some of it's to do, I mean, hopefully, I think there'll be a more focus on acceptability now that we have SecCon's lovely acceptability framework that I think actually helps you so much to tease apart all the different dimensions of acceptability.
Yeah, that's
rather than jumping straight to the feasibility.
Yep. And the other thing I like about that is that it's I'm going to say a lean measure. Speaking like a clinician, I've got this framework here which is saying measure, remeasure, remeasure. being efficient in how we measure is, a really important component here, because I think, it can be really off-putting saying that, we have to look at this at multiple stages, because it is likely to change as we transition. So CCUN's framework and their more recent work on the questionnaire is so lovely and quick. I think there's 7, Steph, you probably remember, I think there's 7 questions in there.
I think so.
It can be done in about 5 minutes. So, it's important for us to find lean, kind of quick ways and yet rigorous ways to measure these concepts.
I think that's a really important point, Marlena, that whole, patients and clinicians, we don't have the time to sort of sit around and answer a 50-page questionnaire on each individual component of implementation. Sort of, everybody has a day job to be doing and a life to live. Kate, you've asked a great question. Yvonne, I saw you had your hand up, but I'm just going to go to Kate's question first, if that's okay. Would you like to ask out loud?
Oh, yes. Thanks so much, Marlena, for that talk, especially as I'm looking at acceptability as the key factor in my work, so that's awesome. However, my thought was just about where you've stuck fidelity. So I just wondered how you thought you would measure fidelity without feasibility. It looks like it's the step before. I just wondered how you might measure that if you, without considering feasibility.
I think they could be considered potentially at the same, well, right now they're often considered at the same time. And again, it's one of those overlaps where often feasibility includes those same constructs as fidelity, which is really, when you look at what fidelity is, it's basically, has it been delivered as it is intended to be delivered? So I guess, the outcomes that we're looking at for feasibility, whether it's, for fidelity, whether you measure it as part of feasibility or as a slightly earlier stage, I think is going to depend on the type of study that you've got, and depending on if you're doing, I guess, a pilot trial. Was that your question, whether you're doing a pilot trial or a feasibility study?
Yes, to some extent, yes, because I can really see how acceptability sits as a good, as you said, common sense first step. But then fidelity is the second in that model, really, as if you could look at that without feasibility, I guess. I'm wondering.
No, that's a really good point. And it's, can you look at it as a precursor to feasibility, which I think would be tricky if you're not doing either a pilot study or some sort of a feasibility study. But what I would suggest is that we should be looking at those fidelity outcomes as an important measure within feasibility. So looking at that sort of adoption, or has it been delivered as intended, and not leaving that out, because a lot of feasibility studies don't necessarily include fidelity measures. Some do, in the same way that some include acceptability, but we would say that it has to include those fidelity measures. I'm not sure that you could include it as an entirely separate measure without actually doing a feasibility or a pilot study. So I don't know. That's an excellent question, and something that we would need to unpack.
Yeah, thanks, Marlena. Great talk.
It's really interesting, isn't it, that sort of order of them? I know exactly what you mean, Kate, because I sort of struggle with fidelity sometimes, because we know it's so important, but where should we be considering it? Yvonne, can I come to you? And then Brendan, thanks for your question. I'll come to that.
I have many questions, but I'll contain myself and just ask 2. So how do you think your framework, and gee, we really like a framework in implementation science, don't we? How does your framework fit in, or does it, with the consolidated framework for implementation research? That's the first question. How does it interact with that, if at all? And I think it has to. My other question is around the idea of acceptability, and what role do you believe co-design plays in actually informing acceptability?
Oh, such good questions. I have so many thoughts on all of those questions, just thoughts and hypotheses. First up, for the CIFA, great framework, and absolutely. So with the CIFA, we've got some inner context and outer sort of context stuff, and we actually refer to the CIFA in our paper. CIFA is primarily used retrospectively. I've seen some indications that it can be used prospectively. Our framework is very specific around perspective, prospectively considering how to approach research, which there is a paucity of in published literature. And yes, you're quite right. There is so many frameworks at the moment, and there is very much this sense of, well, do we really need another framework? Like, aren't they kind of all doing a similar sort of thing? Yet when we go and look at the frameworks, they are largely evaluating, as opposed to really saying, before you start this process, consider this and consider these measures and take them as you're going along. Don't wait until later on. So from an Australian perspective, I know that re-aim is probably the most common one that's used as a kind of implementation measure, but it doesn't really provide you with anything to go by as you're going along. And I'm going to go out on a bit of a limb here, but I would say that what we would propose with this framework is that, rather than waiting to the end to evaluate and go, oh, that didn't work, or parts of it worked and parts of it didn't, is that we could almost set up something like a traffic light system. At what point should you continue going with your study? So if you have low acceptability, what do you do? So if it might be, if it's so low that you don't keep going, or it's just kind of problematic, you should address it, or it's all systems go green, go and move on to the next phase of the study, which I think from the perspective of health resource or health research utilisation, it might be a more appropriate way to say when we should be continuing with the study or not. So we sit quite nicely within the CIFA in terms of inner context stuff, and we certainly acknowledge that there's a lot of out of context stuff, and I think there's a question around that, but we're very specifically aiming for prospective work. And your question around co-design, I think, is really, really timely and really important. And I think co-design is such a great idea, but we don't actually know much around the relationship between co-design and end user outcomes, such as adoption of interventions. So again, it sounds like a good idea, and I'm sure it is from that space of Nothing About Us Without Us, for example. So that campaign's tremendously important. And I think engaging consumers is really important, but it happens on a spectrum of very low level engagement up to, or very high level engagement. But we don't actually know if co-design acts as a mediator. Does it act as a mediator between acceptability and adoption or other end user outcomes beyond it feels good to include end users?
Fabulous, thank you, Marlena. I'm just going to take you to Brendan's question. Brendan, would you like to pose a question to Marlena? That'd be great, thanks.
Thank you. That was a great talk. I'm a clinician who's now getting into implementation research in the antimicrobial stewardship field, and which is I think a really sort of growth area. But what I really like how intuitive your framework is, and I can really see it, going into a grant application, and being very persuasive. Then what I want to ask is how you see it being translated during the project. Like, how do we judge if something's adequately acceptable, faithful, feasible, and who gets to judge that? Is it the project team? Are we trying to persuade other implementation science people? Are we trying to persuade funders? Because all of these things are a little bit contingent, and realistically everyone's invested once a project has started, and that people have been employed, and that project's going to keep going, or people are going to try and get something out of it. So sorry, that was a very long question.
No, I love that question. And I think about this is quite a sad indictment on my life. I think about it all the time. And I've recently been, grappling with how to operationalize all this sort of stuff, exactly as you say, Brendan. Like, so what does it mean in the context of a grant application, which should go ahead at all, not at all costs, but it's going to go ahead no matter what. But what I think we're seeing more recently is, NHMRC, for example, declaring that they've got a problem with adoption. And we are seeing grants coming out saying, we need an implementation plan. We need to understand these factors that influence adoption. And most of what we know about adoption and implementation science is not empirical. So what I'm interested in doing is getting some empirical data around these relationships. And you're quite right. Well, we don't know how much. I don't know how much acceptability is enough. And ideally, that's what I would suggest we need to start researching, is we need to say, this is intuitively a good idea. Let's actually measure this and see how these relationships or these associations look. What do these relationships look like in terms of, if we're using this, CCON's questionnaire, it's based on a Likert scale. Can we do a regression model? And can we map that regression model in terms of adoption and the 7 factors that are included in acceptability, and have a look at, which ones are coming up as having the most effect, which ones, sort of are over correlated. So I think it's an important question that you pose, is that all of this seems like a good idea. It's all very hypothetical, like all theories are. But I think that we're coming into a time now in terms of grant funding where it's reasonable to say we should collect some data around this, and that it has implications for future research if we can identify that there is actually a linear relationship between acceptability and fidelity, or acceptability and adoption of healthcare interventions. Did that sort of answer it?
Yeah, I think so. Thank you. I'm trying to think how I can potentially include your framework in an upcoming project so I can contribute to that empiric evidence.
Yeah. Look, I'd be happy to send you some. I've got some standard tables around what to measure when using the framework.
Fantastic. And I think that there's a really interesting question around, what's enough. And I think it feeds in quite nicely to a paper that we were reviewing at the last implementation science interest group. And we were talking about evidence. So we're talking at the sort of pre-stage to this, we're talking about that clinical utility stage, aren't we? And there's a great table in that evidence paper that kind of talks about, well, how do we know whether we've got enough evidence or not? Not empirical, but it kind of gives you some of the factors that you might want to be considering. So I think it's really interesting for us to be sort of considering these along, and really interesting, Marlena, to hear that you're trying to devise something really quite concrete. And it'll be fascinating to see, won't it? Because we know there are so many influences on this.
Absolutely. And there is context and all that sort of stuff, Steph, and how, they're all kind of confounders, aren't they, in many ways? And this is the thing, when you're working with human behavior, it's all just so wild. And a lot of it is just about describing that in this context, because I can't control the context, this is what's going on. And there's all the sort of organisational stuff. So I think there's an element that's descriptive, and then there's an element that could be.
I can't imagine we're ever going to be able to get rid of all of the subjectivity when it comes to these sorts of measures, and when we're thinking about these kind of contexts. But I think the really key point around what Brendan was saying for me is kind of like, well, who is it who's making those decisions? And for us to be open and transparent about those sorts of processes. Sorry, I shall stop hogging your time, Marlena.
No, I think that's a really good point. And I'm really interested in other people's opinion around, around that, at what point, how much evidence is enough? And, that notion of, who is in charge of how much is enough, and who is in charge of how much is acceptable enough. And I think, again, trying to operationalize or trying to statistically look at these relationships, and at least know that there's a threshold point, maybe. Beyond that, more is good, bonus, extra, nice, but that you can achieve this much. But then I guess it's also about being able to say, well, acceptability is important. How do we fix that if it's low? Because we don't know that either. We sort of think to ourselves, oh, well, acceptability is important, but we actually have no evidence around strategies to address low acceptability. What does that look like?
Yeah. Do we then have to unpick those as individual behavioural characteristics and actually start addressing those? And so do we bring something like the TDF in at that point? So yeah,
I did think about that too.
Helen, did you have a comment you wanted to make?
Well, I wonder if the culture and the fact that we don't always focus on one clinician practicing, but numerous of clinicians, and we've all been trained from a different perspective. If you look like at medical specialists or at nurses, for example, I think that also we all, if I'm talking as a clinician, we've all been trained to use evidence, but when we're practicing, it's pretty hard to
yeah, in real time.
In real time.
That's
so,
yeah.
I think that is why the acceptability might be always an issue in implementing, because it depends also on the person, the clinician, how quickly are they able to adapt to a new way of working. And from my personal experience from the past, I would say it is very hard to adapt to a new way of thinking, new way of working, and putting that into practice, and especially when you focus onto a team. So culture plays into that as well, I think. If it is supported by the top, then it is a lot easier. But again, from experience, the top does not always also support new interventions. And if I'm allowed to say, and as I've said in the beginning, yes, I'm Dutch and I've only been 4 years in Australia, but implementation is really hard, because do we really want to change?
Yes, million dollar question in there.
Yeah. And you're quite right, Helen. It's a difficult one to unpack, because it's very rarely about me being, like, if you look at my earlier example, being evidence-based. You know, I can be as evidence-based as I like and be all over the literature, but if there's all these other contextual factors going on, how likely is it going to be that I'll adopt that intervention? And I think, part of that comes down to some feasibility, feasibility issues. So let's say we do have high acceptability, then, is it even feasible? Because you can't keep stacking new things onto clinicians. Something's got to go. And some of those acceptability measures, which I think are also very clever earlier on, are around things like this perception of burden. So, is it going to be too burdensome? And also, does that change? And I think about this a lot as a clinician, is that it doesn't feel like a burden when you've got, $500,000 of grant funding and, 12 clinicians to help. But if you retested that, when all of that left, does that change? And I'm very interested in that notion of, that acceptability is going to be different once you expect it to be core practice without the resources that you typically have associated with a project, because now it does become more burdensome. And there's other context factors at play there that are different to the context factors at play in the research setting. So I'd love to see some research that actually unpacks that. What does it look like as it transitions from here to here? Because I suspect that's what's going to tell us at least a little bit around why studies show a reasonable level of acceptability, but very, very low sustainability.
The other thing that I think is quite fascinating, Marlena, is this idea of you can have acceptability, but is there something else that also is acceptable, but maybe is more acceptable?
Yeah.
So it's kind of like, yes, thinking about your clinician in practice. Well, I've got 3 practices that I think are acceptable, but actually I think this one's more acceptable than this one. So, but actually it might, it might not necessarily be the one that's necessarily going to have the most impact for the patient, but for the varying different factors that feed into acceptability. But I digress into more of my questions. Just to say thanks, Yvonne, for putting, if people haven't got the chat open, there's a link that Yvonne's putting around complexity and how sort of levels of acceptability are going to change. So I think it was a really interesting paper for us to be looking at. I'm just going to take us back to a question that Samantha has put into the chat. Would you like to ask your question? It feeds in quite nicely to some of the discussion that we've had already.
Yeah, thank you. Thanks, Marlena. That was fantastic. The question I have sort of relates to what Yvonne was saying about co-design and acceptability. It made me think of some of my own work in GP practices with trying to increase the uptake of a screening tool for young people. And the reason I bring up rural versus urban context was the tool was great. The GPs were on board, reception were on board, the gatekeepers were on board, but actually in rural areas it just wasn't working. And some sort of kind of stories that receptionists were saying were that young people don't want to be seen using it in the waiting room because the GP might know their parents. All of these like little things that are associated with the location and the setting, and it's sort of really changed the way the whole thing worked. It looked like, statistically looked like it was working, but then these little things we just couldn't figure out what they were. And then these stories started coming up and these little comments here and there from young people that just you wouldn't figure out from the data.
Yeah, that is so interesting.
Yeah.
Interesting. And I'm not surprised. But what I think is interesting is that the stories are coming from the reception or admin staff, when I wonder, in fact, if you ask the young people, I mean, I don't know if the stories came directly from them as another end user group, whether that was their barrier. So and you've probably already done this, Samantha, is like to actually, go back and do like a TDF, what are the barriers to uptake in that setting? Because context does seem to be a driver. We don't quite know how, all the relationships that context has with, again, it's one of these areas that kind of makes sense that it's going to have an influence, but very little empirical evidence around what that influence is or how that works. But I would actually want to unpack that and go, well, what is the barrier? Is it more that in that regional setting, they're understaffed, so they don't have time to actually give out that extra bit of paper that might be required? So there's often context-specific barriers that need to be, unpacked and not assumed.
Even transitioning between a paper to a QR code, was one of the ways, but they still didn't want to be seen to be actually scanning the barcode. So it sort of was, sort of tried to do a few things, but it was difficult.
I had a really similar experience at a hospital where I worked, where I was told that the reason we had very low rates of asking patients whether they identify as Aboriginal and Torres Strait Islander, and I was told the reason is because staff are racist and they just don't want to ask. And so all this time and effort had gone into implementing an intervention around cultural safety and all this sort of stuff. And actually what happened is that it lowered the rates of asking. So it had the opposite effect. And so my boss came to me and she said, can you fix it? Because that's the sort of thing that happens in a health service. And I said, well, I don't know that you know why people weren't asking in the first place. And so they told me about all these assumptions, these stories. Right. So what I started off by doing was going to the people who are meant to ask, like admin staff, etc., and saying, and I use a very specific tool around, what, sort of looking at why you should ask, when you should ask, all that sort of stuff. And as it transpired, the reason they didn't ask is because the stupid system had these options that you couldn't possibly interpret. It had 17 different options that you could answer. It wasn't just a yes, no. It was all these different things. So they were overwhelmed by the response options in the system. And they were concerned that if somebody got offended, if they asked, how they would manage that. So the actual interventions were very different to what had already been put into place. So that's one of those stories where assumptions are made about end users' experience. And it really helped for me to go back and unpack that and share it. And I had to share it with the board. And it's such a silly story in many ways, because you think, well, that's just like common sense. And a lot of what we talk about as implementation research kind of seems like common sense, but you've got to go back and get the data on it and say, well, actually, 78% said that this is the reason why, and 64% said this. Therefore, our intervention should target this and not this. I don't know if that's helpful, Samantha, but certainly for us, it was going back and unpacking it, and we had a wildly different story.
Yeah. So interesting. Thanks, Marlena.
I think really feeds into what Brendan was saying about who is it gets to decide what the acceptability. So who are we talking to about these sorts of things? I'm really aware that we've got 2 minutes left, but just one last question I've got from Andrea, who is cheating by adding an extra question in, but I will let it, you know, happy Monday.
Thanks, Steph. It's just around other implementation concepts, and I'm thinking about cost as being one of Proctor's ones. I asked because we had, it was actually Bella and I, who's on listening as well, have done a study where we looked at the acceptability of introducing personalized risk scores in a dermatology clinic. Everyone loved it, the clinicians, the patients, the clinic staff. But the sticking point for keeping it going is, I think, probably as ever, resourcing. Because we had a research dermatologist that was paid from the study to involved, and even though everyone loves it, we just, I think, unless we have data to indicate cost effectiveness and the cost of implementation, how are we going to get this sustained long term, even though it's something that is highly acceptable? So I'm just wondering, is cost something that you've bundled up with feasibility? I think that's a short question.
Yep. And cost is, and we haven't specified exactly what should be measured under each of those concepts. I think that there's a lot of different frameworks for measuring, you know, each one's. I mean, we've talked about CCON for acceptability. There's other acceptability frameworks and so on and so forth for all 5 of those concepts. What I would say, though, Andrea, is that, you know, the notion of finding it acceptable, you know, I think that change, as I've said before, is that I think that changes as you start to shift towards, well, let's just make this everyday practice. Yeah? Like, how does it transition from we've proven that it's effective in that context, this is working, you know, this whiz bang, I'm just going to say this cream for your face is working in this research context, but it costs $180, which is, you know, a lot more expensive. When we're shifting towards this assumption that it's going to be absorbed by the clinic, or it's going to somehow be everyday practice, that acceptability isn't the same. And yes, in terms of that's going to be part of feasibility, which is why they're kind of nested in each other, is that if it's no longer acceptable because it costs too much, so the resources, I think pretty sure resources is one of the acceptability constructs, then we need to be aware of that. Because it's all well and good that, you know, we've got the funding to prove that in the research context, but if that shifts, then we need to say, yes, it's effective, but it's not going to translate to everyday clinical practice because it's not acceptable, it's not feasible because of cost. You know, so instead of going, you know, go on, Steph.
No, I was just going to say, I'm afraid I am going to jump in there because we're now at 1:31, so we're a minute over. We could just keep talking for the rest of the afternoon around all of this. There's so many interesting areas for us to explore. I just want to say thank you hugely to Marlena for presenting to us today. And thank you everybody for attending and for your discussion. It's always informative, always makes me think in different sorts of ways. So look forward to seeing you next month. I can't remember what the presentation is. Is Bella on the line here? Because she's usually got a grip on these sorts of things.
Actually, I'm not sure.
You know, Karen will get a reminder out to all of us.
I feel like it's about adoption of healthcare interventions.
But it's likely to be from the Agency for Clinical Innovation.
Excellent. Thanks very much, Yvonne. Thank you very much, everybody. Hope you all have a great week.
Lovely to meet you all. Bye.
Toodaloo.
Bye.